Xin giới thiệu với lại các anh chị và các bạn tiếp theo chương trình thì chúng ta sẽ nghe cái phần trình bày về một chuyên gia chuyên về thuyên tắc mạch. Ông đưa ra hai cái quan điểm lớn, đó là cái tắc mạch trong điều trị trĩ, cũng như là một số cái vật liệu về tắc mạch rộng rãi có thể ứng dụng được ở các nước đang phát triển. Thì chúng tôi xin giới thiệu hai cái bài trình bày tiếp theo là của Professor Vidal. Ông là một chuyên gia về lĩnh vực điện quang can thiệp của Đại học vùng Aix-en-Provence, Marseille 2. Thì tiếp theo là cái phần trình bày của ông. Je vous présente Professeur Vidal. Présente votre présentation, s'il vous plaît.
Hello, I'm very happy to share with you this conference about Emborrhoid therapy, and thank you again for the invitations to your congress. So, as you can see, this is the anatomophysiopathology of Emborrhoids. And it looks really complex. There is plenty of things, but which is interesting to us, it's the blood stagnations with hyperarterial or of the sinusoid, which lead to spurting, hosing, and finally, which will be the main symptoms which is interesting to us. Of course, there are also pain, and we'll see that incontinence, itching, soiling are more related to aging and to the prolapse. So, 15 years ago, around, people asked for these tools, which is Doppler guide hemorrhoid artery ligation, and the surgeons go inside the rectum and do ligations of the suprarectal artery. That means that we propose to do the same thing, but not using internal suture, but doing the same thing with inserting a coil here at the same place, but via an endovascular way. If you look at what is internal hemorrhoids, it is clearly a physiological network. The role of this complex is to participate to the resting anal pressure. So this is 20% of the closing rectal wall, and when it begins to increase in size, it's bleed, and finally it can go out of the rectum. So there are three cushions, and these cushions are mainly vascularized by the inferior mesenteric artery. You see here on this posterior view of the rectum, this is the superior rectal artery, which are interconnected with middle rectal and inferior rectal artery, and the main vascularizations come from the superior rectal artery. So you can see that the anatomy of the suprarectal artery are almost always the same model. There is two main branches, one right, one left, and the posterior trunk, which give a smaller branch. You can see this artery and the entering in the hemorrhoidal cushion. On CT, here you have a CT reconstruction, and you can see here very well how this works. You can see also the artery, but the drainage vein on the CT. Depends on the time you come. You see here the suprarectal artery and the drainage vein, which is there. So here you have the internal hemorrhoids, which can go down and give clearly a prolapse on the, and here you have the Gallagher classifications, which give fourth stage. The first stage, there is no illness. On the stage 2, you have hemorrhoids, which are congestive but without prolapse. On the stage 3, you have a prolapse which is reducting. You can reduce the prolapse, and the stage 4, the prolapse is so important that you cannot reduce it. We have to notice that rectal bleeding are of course related to cancer, but in 5 to 50% of the anemia caused by lower GI bleeding originate from hemorrhoids. That means that people coming to the consultations come often with anemia. Some of them had transfusion, blood transfusions. It's very interesting because the corpus cavernosum recti that you see here, which creates the anal cushions, it has been described in 1964, and you have the artery, which come directly in a venous lake. There is no interposition of tissue between the artery and the vein, and that's why it creates this cushion. You see this small artery coming in the corpus cavernosum recti. You can see it very well in angio. And the role of that is not to bring oxygen to the rectum, because there's no tissue. It's really to create an arteriovenous shunt. And this shunt will create the cushion. That's why you have a red bleeding when people come to the consultation. They said, clearly it looks like arterial bleeding and not like venous bleeding. Interestingly, here you have the illness of the hemorrhoids pathology. So here are people with stage 3 and stage 4 with big hemorrhoids. When you look at Doppler of the superior rectal artery, in these populations, the arterial flow and the caliper, the size of the artery, are bigger than in patients who have no hemorrhoids. That means that if you have big artery, you will develop hemorrhoids. And if you look at the Doppler of this artery, you see that there is a very low resistance index. That means that there is no interposition of tissue, and it's really an arteriovenous shunt. If you look at the arteriograms, here the catheter, it has the distal part of the inferior mesenteric artery. When you inject, it's 2 images per second. You see this is the left superior rectal artery here, and the left superior rectal artery entering here the corpus cavernosum recti. At the time when it comes here, you have here the drainage vein, and there is no interposition of tissue. You see no parenchyma here. It is clearly a drainage vein, and this is the physiological network that we call corpus cavernosum recti, which create the hemorrhoids. So in 2007, we were asking for the first patients, and if we look to the literature, you can see that there are some previous embolization which has been done, but only in emergency for people who bleed with life-threatening emergency. So if there was no ischemic complications in these patients, why will it lead to complications for chronic bleeding? So we have done one of our first case in emergency. It was a young patient, which has had a resuscitation at ICU because he had a massive bleeding 10 days after a surgery. You see here the bleeding. He had a surgery of hemorrhoids, and the wounds bleed. So we go in the inferior mesenteric artery. Here is the left superior rectal artery, and you see here that there is a bleeding in the rectal. So it's for interventional radiology, it's really simple to come here to insert, you see the microcatheter, to insert a small coil, and it does the job perfectly. The surgeons understand very well at this time that if you can do in an emergency way, you can do it for a chronic way. So we use this type of microcoil, which are 2 or 3 millimeters, which are fibered, and we use a Siemens or a Sidewinder catheter to go inside the inferior mesenteric artery. So here is the setup in Marseille. So you can see, for example, a 3D CT of the inferior mesenteric artery. You don't need to do a 3D CT at all the time, but it can be helpful because you have all the images here, you see, of the superior rectal artery. And when you have the 3D reconstructions, you see very well all the branches coming. You can also have an axial view, and you see the artery entering in the corpus cavernosum recti. So you can have these images really nice on your screen. So I try to come with the microcatheter as far as possible, as close as possible as the pubic bone. And you see the distal tip of the microcatheter, which is here. This is the terminal part of the superior rectal artery and with a connection with inferior rectal artery and pudendal artery. And I'm going to insert coil here. You see, I insert small coil of 2 millimeter, and it's nice because it leads to a very quick occlusion. And there is some other branch. So usually you have 2 to 3 branch to embolize here on each side. You see, you can come very deeply with the microcatheter. When you have done the branches of one side, you can go on the other side. Here you see on the right, the microcatheter, which is coming here very close to the pubic bone. You see here, it's very small artery. You see there is small extravasation. Here is a small artery again, which is communications with middle rectal artery. And we are going to inject on each branch some microcoil. I try to go as far as possible. Here you see the final control. Our goal is to have no more artery coming below the pubic bone. And in the final control, you see that here you have still something. So you need to go and check the posterior trunk. This artery, you see, is not blocked. And this artery take in charge this branch, which goes again in the anal canal. And you need to do that to obtain a complete control. And the complete control is there. I have no more artery. So if you look on what this is the insertion of the micro coil, you just have to push, and after you can flush it with liquids. In fact, it's a good technique because it goes quick. You see here the distal tip of the microcatheter and the coil is coming. So it's interesting because it goes quick and do a very nice job. See here again, first will be more magnified. Here you see insertion of the coil which comes. Okay, so the first paper has been published in 2014 with the first 14 cases. Sometimes when you do the inferior mesenteric artery angiogram, you see no artery coming in the rectum. Does that mean that there is no artery? Of course not. That means that it comes from other artery. So here you have to go as far as possible with your microcatheter. And when you inject, here you have nothing. But if you come with your microcatheter in this branch and you inject, you will depict this big artery, which is the middle rectal artery. And the middle rectal artery take in charge the main part of the superior rectal artery. Well, look at that. When the microcatheter is going back in the middle rectal artery, you find all the artery that you don't see from the superior rectal artery. Here is the same. You have here an example of injection, no artery, but how to depict this artery is to go as far as possible. You see here, we have embolized 2 branches on the left, 2 branches on the right from the superior rectal artery. And now we are coming, this is the pudendal artery, this is the middle rectal artery. You see the size of this artery, which takes part of the corpus cavernosum recti. So here is another example. You have left superior rectal artery, right superior rectal artery, posterior trunk. When you go down, you inject, you see up this. This is the middle rectal artery. And you see the size of the middle rectal artery, which is almost the same size. Here's the middle rectal artery. You inject. This is not a vein. This is clearly the middle rectal artery, which is as big as the superior rectal artery. So now we come from the middle rectal artery. And when you inject, you have a backflow here, which comes and try to revascularize the superior rectal artery, which we have embolized. So that means that we have done first embolization of the superior rectal artery. We have found the communications with the middle rectal artery. So you need to embolize this middle rectal artery. If you don't embolize this middle rectal artery, you will not have done all the job. It's really important. So we have 2 types of patients. One type of patients where you have superior rectal artery right and left, and no middle rectal artery or very small middle rectal artery. And of course, there is always an inferior rectal artery. So in this case, you have to embolize only superior rectal artery. And around 30% of the patients have superior rectal artery with big dominant middle rectal artery, which can be unilateral or bilateral. In this case, you have to do embolizations of both, of course. So this is the type 1. You have no middle rectal artery depicted, so do embolization of the single superior rectal artery. And this is type 2. You have here left superior rectal artery with a huge connection with this middle rectal artery. The size of this middle rectal artery is bigger than the superior rectal artery. So clearly you have to embolize here on the left, and on the right is the same, you see. So how to do the embolization of the middle rectal artery? The best, if you have the tools, is to do the CT, the angio-CT. With the angio-CT, you have a 3D roadmap, and with the 3D roadmap, you can do easily catheterizations of the middle rectal artery, which can be embolized. Of course, when we do embolizations with coils, you can imagine that you don't reach the corpus cavernosum recti. If we had the opportunity to insert sphere inside, it can lead to a better result, but it can lead also to ischemia. So at this time, we think that it is still better to use particles. I don't have time to develop all the results, but for the beginning of the procedures, I think doing only coils is clearly the best. The point which is very important is that patients come for functional symptoms. So you need to speak with them at the consultation and say what is the definition of the clinical success. And the clinical success, which has been defined in this Lancet study about ligations of hemorrhoid versus Doppler ligation, is at 1 year, do you feel your symptoms from hemorrhoids are cured or improved? This is a clinical success. Or if it's unchanged or worse, this is a failure. And it's really important to say to the patients, okay, we are, see, how do you feel? And there is plenty of score, hemorrhoid severity score, incontinence inventory, pain, but they are not relevant of what the patients feel. And finally, which is the most important, is what the patients feel. So we have created also a bleeding score because there was no bleeding score. This bleeding score is important for us because we are treating most of the patients which come with rectorrhagia. They come because they have hemorrhoid stage 2, stage 3 with bleeding. So it's important to have a score. So if we look at all the theory which has been done, we can say that the technical success is good, is around 100%. It's not a big challenge to do with embolizations. The clinical success leads to 70 to 85%. It depends on what is the definition of the clinical success. It depends on plenty of things. If we look at all this theory, no major complications has been described, but they are not really comparable because they are not looking for the same thing, the different score. Anyway, now we have some clinical study which are a really nice way. And now we have a study about transradial access, I think, which is great technique because the patients can go home and work really easily. And there is also some meta-analysis which give clearly the clinical evidence of this treatment. I don't have time to go deeply in this meta-analysis, but so finally, what can we say about Emborrhoid? We can tell that does it work? Yes, the embolizations of the suprarectal artery and middle rectal artery works for bleeding. That means that when the patients come and said, my trouble with hemorrhoids is bleeding, in 80 to 85% of the case, you will have big ameliorations on bleeding and the patients will be happy. When a patient comes because he has pain, it's complicated, and be sure that the pain is related to hemorrhoids. If the patients come and said, I have pain so intense that I cannot sleep, for example, usually it's not hemorrhoids. It can be fissure, it can be hypertony of the sphincter, it can be a lot of things. So works with proctologists, with surgeons to be sure that the pain is related to hemorrhoids. When a patient comes because the main symptom is prolapse, If you reduce the blood flow, you will reduce the size of the hemorrhoids. But if there is a stage 3, stage 4 prolapse, which is the main symptoms, the patients will have perhaps not enough ameliorations to be happy. So the main patients which need to be treated by emborrhoid is the patient which bleeds clearly. The level of evidence, of course, we need still a randomized trial. There is a randomized trial which has been done in Brazil, but which is still not published, just been presented in a congress. You have to remember that hemorrhoid recurrence at 1 year with emborrhoid, it's around 25%. And with Doppler ligations, it's 30%. And with rubber band ligations, it's 49%. That means that we have very good results with a technique which is minimally invasive, because there is no wounds in the rectum. So the main thing is to have a good selection of the patients bleeding. You need to treat the middle rectal artery also when it's a stage 2. I think doing embolization with coil is the best because it's completely safe. And for follow-up, you have to look at the patient and say, is he happy or not? Thank you for your attention.